It's time for a warm-up review. Let's get going. What is the function of the lysosome? So the lysosome is going to contain the enzymes that break down cellular wastes and cellular debris. Next, what are the characteristic features of a cell undergoing apoptosis? So you get lots of things. You get cellular shrinkage, you get nuclear shrinkage, which is called pycnosis. You have karyoresis, which is fragmentation of the nucleus. You have karyolysis, which is fading of the nucleus. You have apoptotic bodies that are going to be formed, and then you're going to have membrane blebbing. Next, how do BAX and BCL2 affect apoptosis? So remember that BAX promotes apoptosis, it's given the X to the cell, and then BCL2 is actually going to inhibit apoptosis. All right, that's it for the review. Let's get to that lecture.
In this video, we're going to focus our attention briefly on CSF. Now, despite what you may find on Wikipedia, CSF does not stand for the Colorado Shakespeare Festival, the Canadian Snowboarding Federation, the Caltech Satanic Fellowship, or even classical swine fever. Although that's getting closer, I guess. Honestly, the fact that there are diseases out there called hog cholera and bovine viral diarrhea make me very glad that I chose med school over veterinary school, but I digress. Now, the CSF we're interested in is the cerebrospinal fluid, which bathes the brain and the spinal cord, acting as a cushion and support for the brain, as well as tightly regulating the electrolyte concentrations and dissolved gases that contact the brain. So in this video, we're going to talk about a couple of disorders that involve the CSF. Let's start by reviewing the anatomy of the ventricular system and the circulation of CSF. There are two lateral ventricles, which are connected to the third ventricle, and that empties into the cerebral aqueduct and eventually to the fourth ventricle, which continues as the central canal of the spinal cord. So where does CSF come from? Well, it comes from the choroid plexus, which lines the ventricles. Now, from the lateral ventricle, the CSF flows into the third ventricle by way of the foramen of Monro. And from the third ventricle, it flows through the cerebral aqueduct into the fourth ventricle. And then from the fourth ventricle, it enters the subarachnoid space by way of the foramen of Luschka and the foramen of Magendie. And from the subarachnoid space, CSF is reabsorbed in the arachnoid granulations back into the superior sagittal sinus. The superior sagittal sinus is one of the dural venous sinuses, which are sort of channels within the layers of the dura where venous blood can flow. The superior sagittal sinus basically runs along the top of your brain in the midline, and this is where you find the arachnoid granulations that return CSF back into circulation. Then toward the back side of your head, on each side, you have the sigmoid sinuses, which is the last place that the blood from the brain travels through before it exits the cranium through the jugular foramen. And as the sigmoid sinus passes through the jugular foramen, it becomes the internal jugular vein. The internal jugular vein is found in the carotid sheath along with the vagus nerve. So you have three very important structures found within the carotid sheath: the carotid artery, the internal jugular vein, and the vagus nerve. Let's talk about what happens if the flow of CSF is interrupted. If the flow of CSF is obstructed anywhere in that pathway, from the lateral ventricles to the third ventricle and the aqueduct to the fourth ventricle, the CSF pressure is going to build up behind that obstruction, and that pressure causes the ventricles to dilate and expand. We call this a non-communicating hydrocephalus, or an obstructive hydrocephalus, because the communication between the ventricles has been obstructed, so it's non-communicating. Now, this can lead to severe headache from elevated intracranial pressure. It can lead to papilledema and uncal herniation with a blown pupil and possibly that down and out eye from a cranial nerve 3 palsy. And ultimately, it can potentially cause death. A communicating hydrocephalus occurs when there's no apparent obstruction. Everything appears to be flowing through the ventricles normally. But what's happening is that there's poor reabsorption of CSF at the arachnoid granulations. And that results in the same findings: increased intracranial pressure, headache, papilledema, and herniation. There's also something called normal pressure hydrocephalus. This is where there's expansion of the ventricles due to impaired CSF absorption, but when you measure the intracranial pressure, it's normal. But there's still no obstruction of flow within the ventricular system. And in order to recognize normal pressure hydrocephalus, you need to know the triad of symptoms: urinary incontinence, dementia, and gait disturbance. Now, the mnemonic here for this is wet, wacky, and wobbly. So wet is that urinary incontinence, wacky is the dementia, and wobbly is the gait disturbance. Now, the gait disturbance in normal pressure hydrocephalus is described as a magnetic gait, like there are magnets stuck in the patient's feet, sort of holding the patient's feet to the ground. So they take these very short, low amplitude steps. So make sure you can recognize that triad: incontinence, dementia, and gait disturbance. And normal pressure hydrocephalus is a cause of dementia that is potentially reversible. Most causes of dementia we'll talk about are irreversible, but this is one you'd actually like to be able to diagnose because you can put in a shunt and get that excess fluid out of the brain and the symptoms all resolve. There's another pathology that looks like hydrocephalus on CT, which is called hydrocephalus ex vacuo, or sometimes it's called ex vacuo ventriculomegaly. So it looks like there's dilation of the ventricles, but in fact the ventricles are not dilated. It's just that the brain tissue around the ventricles has atrophied, so the ventricles appear enlarged by comparison. That's why it's called ex vacuo. There's sort of a vacuum that gives the appearance of hydrocephalus. The main place you're going to see atrophy of the brain tissue is in dementia patients, like patients with Alzheimer's disease. Now, in your study guide, there's a table that compares all these different types of hydrocephalus, so let's fill that out together. All right, so in this table I've listed several different types of hydrocephalus, and let's compare some of the different features of these. The first one is non-communicating hydrocephalus. We said this one is caused by obstruction of CSF flow. Then we'll skip intracranial pressure for a second and talk about the signs and symptoms. This can cause headache, it can cause personality changes, it can cause lethargy, it can cause papilledema, and it can cause cranial nerve 3 palsy and blown pupil. Then the next one is communicating hydrocephalus. Communicating hydrocephalus, we said, is due to impaired CSF absorption. And what part absorbs the CSF? The arachnoid granulations. Now, the signs and symptoms for communicating hydrocephalus are basically going to be very similar to the non-communicating hydrocephalus. And then we have normal pressure hydrocephalus, which is also due to impaired CSF absorption. And the main difference between normal pressure hydrocephalus and communicating hydrocephalus is with the intracranial pressure. So with communicating hydrocephalus and non-communicating hydrocephalus, you have increased intracranial pressure. But again, with normal pressure hydrocephalus, the pressure is normal. Not too big a surprise. Then the symptoms and signs that you see with normal pressure hydrocephalus, we said the mnemonic was wet, wacky, and wobbly. So this stands for urinary incontinence, wacky is dementia, and wobbly is that gait disturbance. And then finally we have hydrocephalus ex vacuo, which is not really a kind of hydrocephalus, but it looks like hydrocephalus on scanning. And this is caused by neuronal atrophy. And again, the intracranial pressure is normal. And the signs and symptoms you're going to associate with this are dementia, because actually it's the neuronal atrophy that we see with things like Alzheimer's dementia that cause hydrocephalus ex vacuo. So as a reward for you, I'm going to draw you a picture of my uncle. And you'll notice with my uncle that his pupil is dilated and his eye is deviated down and out because he has a cranial nerve 3 palsy. So his name is Uncle Herniation. Now let's talk about idiopathic intracranial hypertension, which you may know by the name pseudotumor cerebri. In idiopathic intracranial hypertension, there's elevated intracranial pressure, but no hydrocephalus. So it's the opposite of normal pressure hydrocephalus, in which there's hydrocephalus without elevated intracranial pressure. So let's look at the study guide. What are the characteristic features of idiopathic intracranial hypertension? Well, the classic patient is a young, obese woman. They get daily pulsatile headaches, generally worse at night or early in the morning, possibly with retroocular pain, pain behind the eye that's worsened by eye movement. And these patients may also have some nausea and vomiting. They have papilledema and elevated intracranial pressure, which is why this is a pseudotumor, because clinically it looks just like a brain tumor. The most worrisome sequela is vision loss, which is one reason we treat this. That elevated intracranial pressure is squeezing the optic nerve and potentially damaging the optic disc. On CT scan, you do not see ventricular dilation or hydrocephalus, and there's no tumor or intracranial mass. You might expect to find a tumor based on the clinical picture of headache and papilledema and elevated intracranial pressure, but this is a pseudotumor cerebri. It's a false tumor, if you will. And when you do a lumbar puncture, the intracranial pressure is elevated. That's the hallmark of idiopathic intracranial hypertension, elevated ICP. In a non-obese patient, the CSF pressure should normally be less than 200 millimeters of water, and anything higher than that would suggest idiopathic intracranial hypertension. But in an obese patient, obesity raises the intracranial pressure a little bit, so the normal baseline is a little higher in obese patients. So the cutoff becomes 250. And then the next question says, how is idiopathic intracranial hypertension managed? We're going to discontinue any inciting agents like excess vitamin A, isotretinoin, tetracyclines, or danazol, because these can raise the intracranial pressure. The next bullet is weight loss in obese patients. And then the next one is acetazolamide, which is our first-line pharmacotherapy because it slows down the production of CSF. Then there are also some invasive treatment options. Serial lumbar punctures to draw off some CSF and keep the intracranial pressure low. You can do optic nerve sheath decompression and also lumboperitoneal shunting, or a CSF shunt, to keep that pressure lower. And while we're talking about lumbar punctures, let's review a couple of tiny points of anatomy. When you perform a lumbar puncture, what are the layers of tissues that the needle penetrates? This is one of those odd anatomical things that you might be tested on. You start with the skin and the superficial fascia. Then the needle goes through 3 ligaments, the supraspinous ligament, the interspinous ligament, and the ligamentum flavum. And then you enter the epidural space. Now there's no CSF in the epidural space, but there are some nerve roots here, so this is a great place for epidural anesthesia. So someone in labor that's getting an epidural has local anesthetic like bupivacaine or maybe the opioid like fentanyl placed in that epidural space. But if you're trying to get to CSF, you need to go deeper. So from the epidural space, then you go through the dura mater into the subdural space, and then through the arachnoid membrane and into the subarachnoid space, and that's where you find the CSF. Now, if we give anesthesia directly into that CSF space, that's called spinal anesthesia, not epidural anesthesia. There's a difference between epidural anesthesia and spinal anesthesia. We use both in labor and delivery. Spinal anesthesia is more potent. That's typically what we use for a C-section. And then real quick, let's talk about the landmarks you use to do a lumbar puncture, or an LP, or the common layman's term is a spinal tap, but that's nitpicking, isn't it? In adults, the spinal cord goes all the way down to L1 or L2. So when you do an LP, you want to insert the needle below that level, between L3 and L4, or between L4 and L5, to make sure you're not hitting the cord. So you can remember, go between L3 and L5 to keep the cord alive. And in children, you need to go even lower than that, between L4 and L5, or even L5S1. As you grow, the cord kind of migrates north in the spinal canal just a little bit. So if you imagine a horizontal line between the top of the iliac crest, that's going to help you identify the L4 vertebra, and you can palpate around and identify the spinous processes and then go between them. All right, let's pause the video and work through the end-of-session quiz. First question, where is CSF generated and where is it reabsorbed? So it's generated by the choroid plexus and it's reabsorbed by the arachnoid granulations in the superior sagittal sinus. Next, what's the difference between communicating and non-communicating hydrocephalus? In communicating hydrocephalus, you have decreased absorption of CSF at the arachnoid villi. In non-communicating hydrocephalus, there's a physical, mechanical obstruction of the ventricles. They both cause hydrocephalus, just in different ways. And the last one, what clinical features characterize normal pressure hydrocephalus? Well, again, the mnemonic is wet, wacky, and wobbly. Urinary incontinence, dementia, and gait disturbance. All right, that's it for now. I'll see you next time.